So ALL basically it is defined as a group of neoplasms containing lymphoblasts. So lymphoblast is immature blast cell. It is immature precursor B cell or precursor T lymphocyte. So if precursor B cells are present, it is usually occurring in childhood and it presents as a leukemia. But if precursor T cells are present, that is T lymphoblastic leukemia or lymphoma, it usually occurs in adolescent males and it presents as a lymphoma. Usually thymus is involved. That is why in the symptoms you can see mediastinal thymic mass. Moving on to molecular pathogens, see, numerical abnormality we see is that hyperploidy is seen. Hyperploidy is a favorable prognosis. That means more than 50 chromosomes. Hypoploidy is an unfavorable prognosis. Then structural abnormality, we can see balanced chromosomal translocations such as Philadelphia chromosome, which represents a bad prognosis. So TALLs have mutations in the Notch1 gene. So T, in Notch spelling you have T, right? So TALLs mutation in Notch1 gene, and BALLs they have mutations in PAX5, E2A, EBF. PAX5, E2A, EBF. And then balanced translocation, right? 1 to 12, reverse it to 1. So translocation 12, 21, reverse. Next, moving on to the clinical features. Age, it presents between 1 to 5 years of age and again 30 to 40 years of age. Okay, slight male preponderance because leukemias usually occur in adolescent males. Okay, based on age you again have prognosis. So 2 to 9 years it is a favorable prognosis. Less than 2 years and greater than 9 years, bad prognosis. Next, onset is abrupt onset. Symptoms, basically in bone marrow you have pre-B cells and pre-T cells. They are not letting the bone marrow do its function. So you have pancytopenia of everything except WBCs because they have to increase as it is a leukemia. So anemia is there, normocytic, normochromic. There is fatigue and weakness because of anemia. Neutropenia is there. Neutropenia decreases, but lymphocytes you can see more. As it is a leukemia, WBCs have to increase. Lymphocytosis is seen, but neutropenia is seen. Because of neutropenia, bacterial infections and opportunistic fungal infections they develop and sore throat develops. Next, thrombocytopenia. Because of that, there is bleeding into the skin and mucosa in form of purpura or ecchymosis. Next, there is bone pain because of bone marrow failure. So again, that only you can see bone pain and tenderness, sternal tenderness. Next, lymphadenopathy because ALL in the name itself you have lymph. So lymphadenopathy in 75% of patients, usually cervical lymph nodes, and mediastinal thymic mass, it is common in TALL in adolescent males, and also hepatosplenomegaly. Splenomegaly is more common than hepatomegaly. Lab findings. So basically total WBC count is markedly raised, platelet count is reduced, hemoglobin is reduced. There is normocytic normochromic anemia, right? So anemia, hemoglobin is reduced. So in the peripheral smear, you can see normocytic normochromic anemia in RBC. WBC, the count is markedly increased with 20% or more lymphoblasts. So morphology of lymphoblasts, here you can see. So they have scanty cytoplasm. Okay, they don't have any granules in the cytoplasm. The nucleus has condensed chromatin and nucleoli are absent or either inconspicuous, and there is scant basophilic cytoplasm. There is high NC ratio. The nucleus almost fills the whole cell. It is larger than a small lymphocyte. Okay, 2 to 3 times larger is lymphoblast. Myeloblast is 3 to 5 times larger than a small lymphocyte. Platelets, again you can see thrombocytopenia. Again, bone marrow is hypercellular. Why? Because of pre-B cells and pre-T cells are lymphoblast cells. But erythropoiesis is reduced, myelopoiesis is reduced, and megakaryopoiesis is reduced. And again, blasts constitute 20 to 100% of the marrow cells. Cytochemistry, lymphocytes show pass positive, block positivity, and myeloperoxidase negative, Sudan black B negative. Because myeloperoxidase and Sudan black B are positive for myeloblasts. Immunophenotyping, alt TADATA, so terminal D-nucleotidyl transferase is present in pre-B and pre-T lymphoblasts. See, B cells are common for 19 and 10, CD19, CD10. 10 is Kala, common ALL antigen. Precursor T cells, remember 2 into 4 is 8. Okay, instead of 4 put 5. So CD2, CD5 and CD8 positive. So here you can see, draw RBCs, normocytic, normochromic, and then draw lymphoblasts. Okay, with condensed chromatin, high NC ratio, scant cytoplasm. Okay, and also nucleoli, some are prominent, some are not. Biochemical findings, remember all uric acid increases, ALL, LDH increases. In CSF examination, you do it to rule out the CNS involvement because CNS involvement is an unfavorable prognosis. So age 2 to 10 years is favorable, below 2 and more than 10, it is unfavorable. So white females, favorable prognosis. Next, total WBC count, if it is low, then it is favorable prognosis, and blast cells less than 100,000, it is favorable. If CNS involvement is absent, it is favorable. Hyperploidy is favorable. Philadelphia is unfavorable. And that's it. And finally, moving on to the subtypes of the cells L1, L2 and L3. See, you have to describe nucleus, you have to describe cytoplasm and cell size. Cell size, small, large heterogeneous, large homogeneous. Okay, small, large heterogeneous and large homogeneous. Next, shape of the nucleus. In L2 you have to remember that there is clefting of the nucleus. See, here you can see clefting of the nucleus. In other shapes, in other types, the nucleus is regular. Next, chromatin is condensed in L1, it is dispersed in L2 and finally stippled in L3. Next, nucleolus is small here, visible and prominent. Next, cytoplasmic characteristics. See, cytoplasm is scanty, variable, abundant. Next, basophilia, it is slight to moderate, variable and strong. Here you can see basophilia, right? It resembles a basophil. And cytoplasmic vacuolation is present and prominent in L3 type. Okay, whereas it is variable in L2 and absent in L1.